Good evening, and welcome to another Attire seminar hosted by HUMA, the Institute for Humanities in Africa at the University of Cape Town. I'm here in Cape Town, and we have colleagues who are here with us from the same city, as well as audiences from all over the world. And we're very honored today to have as our guest Josiane Tantchou, who is streaming in from Paris. And we're very excited to have Josiane today because Josiane's work speaks directly to our Future Hospitals research strand at HUMA. So for the last 2 years almost, we've been looking at, a number of our researchers have been looking at the idea of the future hospital in Africa in a Carnegie-funded research strand in which we're looking at artificial intelligence, the so-called fourth industrial revolution, and other ideas about technology and healthcare in Africa and what the future of hospitals looks like. And we have researchers who are working in a number of different countries on the continent to look at that. I've been doing some work in Cape Town, looking at both the public hospitals and private hospitals. In fact, I was a patient in a private hospital last week, where I was spent a few days in hospital, and I'm intertwining my personal experiences of hospitals with my research. Science and technology studies is also an area which I think it's really great to hear from in relation to African healthcare. I looked at science and technology studies as part of my PhD research about 10 years ago, and I was really interested in picking out some of the strands from the paper that Josiane shared with us in relation to that. So Josiane is a research fellow at the Centre National de la Recherche Scientifique. Apologies for mangling this with my high school French, but the National Center for Scientific Research in France. And she has a PhD in social anthropology and ethnology. And her current research focuses on the perception of space and the agency of the built environment. So on our website, we've made available a paper by Josiane, which looks at the idea of infrastructures, and especially portals is the word that came to my mind when we talked about doors and gates and entrances to hospitals. And Josiane's paper looks at, both the very literal sense of what a gate and a door is and entrances, but also what the symbolic value is of these apertures and gateways and entrances into healthcare. And the part of the work that this is based on, and I'll just very briefly describe it, and Josiane will say more. It refers to a conference that was held in 1978 in Alma-Ata, which looked at African healthcare systems and projected this into the year 2000. The overall objective to achieve was health for all in the year 2000. I also thought that was really fascinating, and I'd love to hear more about this idea of futures. So what in 1978 did the future of healthcare in the year 2000 look like, and how do we receive this in the year 2022, looking back at 1978, looking at 2000? We're now about like halfway placed, but I think we're exactly halfway placed in that sense, 1978, 2000, and 2022. So Josiane, we're very warm welcome to you. We're very excited to hear from you. I know you have a presentation to share with us. We usually spend about half an hour or so on the presentation, and then we discuss afterwards with the audience. So please go ahead. And you can unmute.
Can you see my presentation?
Yes, that's in presentation mode. Perfect.
It's okay.
Very good.
So thank you. I'm really very thank you for the invitation, for giving me this privilege, to share some of my crazy thoughts with you as an anthropologist working in a hospital setting since the end of the 90s in Africa, and then since 1 year in France. I'm really scared because the paper I want to discuss I didn't have any chance to share, to discuss those data with a team of multiple disciplines. So yes, let's go. I want to talk about access to healthcare facilities in Africa, as you read, since 40 years after Alma-Ata. And you know that Alma-Ata was the conference that contributed to in the shaping of health systems in most of the African countries, and where was issued the idea of health for all by the year 2000. And I think you can also see that we are still expecting that to come. When I sent the paper, after sending the paper, I was a little bit confused about how to organize my presentation. So I would try to be like, not talk too much, and that's going to be difficult, but I'll try to allow for discussion. Another thing I want to stress is that personally, I'm really, really deeply concerned about poverty and the way to which we can simplify access to acceptable cures and care to the poorest. I speak from Cameroon, where I did field work from 1997 to 2014, and Morocco, where I did field work from 2014 to 2017 in primary healthcare facilities, university hospitals, and private practitioners. I also had the opportunity to have discussions with patients with chronic diseases, pregnant women, HIV positive people, and organize focus group with women to learn more about their experience of the space of care and hospitals in particular. And at the end of my presentation, I will use data from France. So accessibility 40 years after Alma-Ata. In what follows, I want to start by defining what we can understand by accessibility. And then using the data from my fieldwork, I'll focus on two features that, in my view, can be associated with access, doors and gates. And at the end, I'll try to, bring some data coming from healthcare providers about how they see the hospital of the future, or the future hospital, or whatever you may want to call that. So accessibility, access to healthcare is about enabling a patient in need to receive the right care from the right provider at the right time, in the right place, depending on the context. This last one is very important because when we look at the university hospital, for example, we can see that the shape of the university hospital and even what the representation are coming from the European standards of biomedicine and even perception of health and healthcare practices. And we can observe when doing field work in university hospital that there is a kind of gap between what is expected from patients and healthcare providers according to the shape of the space and what really, really happens. So this idea of enabling a patient in need to receive the right care from the right provider at the right time in the right place is really, depending on the context, is really, really important. So in the paper, you can see the definition of Peshansky and Thomas. They will define access as the degree of fit between the clients and the system. And they have identified 5 factors that will affect access: availability, accessibility, accommodation, affordability, acceptability. I'll not go into those definitions. I just want to sketch to focus on accommodation, the manner in which supply resources are organized to accept clients, and the client's ability to accommodate to these factors and their perception of their appropriateness. This is where I will really focus. So now, let's give some examples. Talking about accessibility, I will take the example of Morocco. As mentioned, accessibility is the relationship between the location of the supply and the location of clients. If you take it, and you have to take into account transportation, travel time, distance, and cost. So taking the example of Morocco, if you look at data from the Ministry of Health, you will see that the main distance to reach a healthcare facility is more than 200 kilometers. And you will see a huge difference according to location, 13 kilometers in urban area and 38 kilometers in rural areas. So on average, it will take at least 35 minutes for those living in urban areas to reach a healthcare facility and 77 minutes for those living in rural areas. So you will have like at least 40% of patients who are over an hour away from the nearest healthcare facilities. And now when you consider hospital care, you will see that people in rural area will spend at least 90 minutes to reach a healthcare facility, the gate of a hospital, and people in urban area like 53 minutes to reach the gate of a hospital. So now let's come to gates. And when we talk about gate, we talk about accommodation. And you remember accommodation, we are in the idea of how supply resources are organized to accommodate clients. What I can see from my fieldwork is that gates are not neutral features. They are places of physical and symbolic violence according to status. On my field, differential treatment is very common in hospital settings, meaning that people are treated according to their connections and the amount of money they are able to spend on care. And one colleague commenting about that, about the university hospital in Morocco, she said, you know what? I think it is easier to get inside the hospital by car than by walking. Because when you are in your car, the security guard at the gate, they don't know who you are. So they will just let you go in. And when you come walking, and you're like, wow, I'm coming from a village. You don't know how to stand. You don't know how to ask. You don't have the discursive practice that that can show that you know how it functions in this space. They will treat you differently. So gates are places of symbolic violence, or what a doctor would call poorly oriented psychology, because sometimes you have this succession of iron bars, you have a security guard for the theoretical purpose of security, but instead, in reality, this only renders patients more aggressive because of the feeling of being excluded from what should be a right. Gates are also places of economic activities. Health workers are not provided with like a place to eat, a restaurant, a canteen inside the hospitals I studied. The wealthier can take an hour to go back home for lunch, but some of them will just go out at the gate to buy, something to eat, a snack, a sandwich, or a drink. And this led one nurse to complain about. She was saying that now they are asking us with this chronic disease to enforce good eating habits. But how can we do that when we are not provided with help to eat well? Gates are also places of financial transaction, because in this hospital, you don't use a credit card. You pay cash or you use a check. And sometimes because they spend the day receiving and giving back money, cashiers are going to be in lack of devices, and they will need everyone to come with the exact change to pay for the services. Then the vendors at the gate are going to help with that. You can go to a vendor and ask for change in order to pay for any service you would like to have at the hospital. So as Zaman highlighted, there are frequent communication between the inside and the outside of the hospital. It is not possible to consider a hospital today as a kind of microcosm, just, something somewhere very, very close. It is the hospital cannot function without the outside of the hospital. So gates doesn't enclose and doesn't mark the frontiers of the hospital. Maybe the physical frontiers, but if we refer to functionalities and the roles needed for the daily working of the hospital, the gates will stretch. So when you reach the gates, now you will probably have to go through a door. It might be the doors of an elevator, doors of an office, a room, or a lab. I'm not dealing with elevators. They can be a subject, a very, very interesting subject when you talk about hospitals. Like gates, doors are not neutral. As you know, walking through doors to enter the hospital settings can really be traumatizing. Doors can open on a gloomy and dirty corridors, or they can lead to the surprise of entering a space full of lights, wide, clean, very, very clean space. And that's sometimes how you recognize spaces where wealthier patients are hospitalized. Natural lights, windows, plenty of space. So doors reveal status and functionality. They will clarify who is authorized and not authorized. They will help to manage privacy. They will enable a retreat from people. They will allow to exert a kind of control over information and to regulate interactions and even to create on space. Yet, when you are in a hospital setting, creating your space, it means establishing boundaries, like who is allowed to enter your space. It means creating connection. It means, you have to, having the opportunity to close your door or to open it just when you want. And in one of the services I studied, where hospitalization was free of charge, doors were always open. So when you are staying in a hospital for a long period of time, you may need privacy, the possibility of being alone, of feeling your body, or refusing to be disturbed, or refusing to communicate. And that will be only possible if you can afford a private room with a door you can open or close. People in those rooms are not treated like people in free of charge rooms. So door is really something symbolically important. It can reveal many details about hospital life. In the context I studied, doors are really rarely sliding. You use your hands to open the doors, and you don't have any water spots or disinfectant that are common now. They were not all common at that time. Even today, they are still not common. And you will have doors opening from inside out, and they are noisy, so that you will have to cross the door to enter a doctor's office. And doctors will rarely be alone with their patients in a consultation room. And even in that case, waiting in a corridor or in a waiting room space, you will hear the door of the doctor's office open quite frequently. And as I mentioned, they are noisy. So as the doctor is talking with a patient, you will hear a knock, then the twist of the door, then the handle, then the creaking of the door opening, then a question and an answer, then the twist, the creaking, and sometimes the snap of the door lock. And these noisy doors in noisy waiting spaces led some patients to complain about their blood pressure, saying that while they wait inside, waiting rooms, the blood pressure will increase. And a doctor even hypothesized the idea of a waiting room related increase in blood pressure or stress. I always try to think about this idea of waiting that is common in a healthcare facility. And I think you heard the expression, you are patient, you wait. A patient should wait. So when we organized focus group with women, they said, when you go to a hospital, you have to be prepared to spend at least the first part of the day for one consultation. You can spend even the whole day. A woman will say, you wait to enter the healthcare facility. You wait to see the doctor. You wait to know if he is available. You wait to know if you're going to be consulted. Then after waiting for hours, while you had an appointment, you will hear that finally you're not going to be received. Then you will have to wait to have another appointment. So maybe she's exaggerating, but during my fieldwork, I really saw patients waiting 30 minutes in a healthcare facility, as well as those spending an hour or 2.5 hours waiting their turn, mainly those with chronic diseases. And I was discussing that with a doctor, and she said, if we want our patients to go back home without any worries, we should give each one of them the time he needs. Moving forward with this idea of waiting, it seems to me that it is not only a passive experience or a state. Waiting is an experience that is it's an experience with and through a mindful body. It's an active and dynamic process that will happen in a waiting room. So I thought it can be conceptualized as a sphere, the waiting room as a sphere of coexisting multiplicity. And then you have multiple bodies and multiple temporalities coming to clash in this waiting room that can lead into those patients be like, man, leave me alone. And then to complain about this blood pressure, increasing. This coexisting of temporality, the heterogeneity of body, having this to coexist or to be, to coexist smoothly, I think is going to be one of the challenges of the, maybe to take this into account when thinking about the future hospital or the hospital of the future, whatever you want to name it, allowing the heterogeneity and the multiplicity, the multiple temporality to coexist in a smooth, how can I say it? Yes, to coexist smoothly. Anyway, so noisy spaces will drain mental and emotional resources, and that will undermine patient-provider relations. And when I tried to, I've considered the heuristic value of the use of space in order to explain what was coined the attitude problem of healthcare provider. You know, that they're kind of rough, they sometimes they insult patients. And I was trying to connect that to the space of the hospital, how it is shaped and how it is configured to allow for a kind of fluidity in the health workers' daily activity. And I was suggesting that this attitude, what we can term attitude problem or tension, is related to a continuous process of translation and anticipation of space and duty to the daily activity of healthcare provider. And I found Madeleine Acris's description of a technical object to be really, really useful in order to think in that way, you know, trying to imagine how the shape of space can have an impact on interaction in a hospital setting, on emotion and on mood. So I came to the conclusion that when you draw on Acris's description of technical objects, and you also use Michel Lusseau's concept of pragmatic of space, you can see that care is also an art of tinkering with space and unpredictable body, or tinkering with unpredictable bodies in unstable hospital spaces. So back to doors. Doors will also be reassuring because behind the doors lies the possibility of a diagnosis, a treatment, just a solution to a patient's problem, and patient problem that I define according to Begg, meaning that whatever a person or his environment perceives as a problem for which a doctor has to be consulted, and the problem will be solvable when the doctor will be able to propose a disposal, a set of action. This does not imply that the problem is resolved. It's just that the physician, the doctor, knows what to do next. But as I've tried to show, between the first symptoms and entrance into the hospital, into the doctor office, there's a long way. Mechanic emphasized the affective dimension of health-seeking behavior, and perceptions of trust in the provider are essential. Many research in Africa have highlighted the negative attitudes toward patients as barriers to the use of available care. Insufficient human resources for healthcare, high workloads, and low incomes have been put forward to explain health provider negative attitudes. But I think the shape of space should be considered. I believe in healing architecture, or architecture as an instrument of care. That is now something very, very common in many countries. And I also believe in the strength of architecture to tackle the issue of infrastructural violence, poverty, and social suffering. So I think access to care is not just an issue of geography. It is also the way healthcare facilities are arranged to provide care. When the doctor mentioned the idea that the waiting room raised blood pressure, I think she was also highlighting the need to rethink spaces of care. If waiting is organically connected to the provision of care, then there is a need to rethink the spaces so to allow smooth connection and continuum of multiple spaces, from places of living to the hospital, or from the hospital settings to houses. The smooth coexistence of heterogeneity and multiple trajectory. So it's a way of saying that when focusing on the hospital, we have to have in mind that the hospital is in a city. So you need to move from your place of living to the hospital, and that should be smooth. You don't have to be, upset by transportation and everything. That only contribute to put you, into to stress and anxiety. So when thinking about the hospital, we have to think about the hospital in a city, in a continuum. So infrastructure are really important because that's the materiality that will configure the interaction in space, within space, and the connection within places and the hospital. So in this respect, besides the desire to work in space, I discussed with a health provider of what kind of space they will need, what kind of space is perfect for them. And among the answer, beside the desire to work in spaces that will allow them, like to be to order, but while saving or giving them the opportunity to be with their self, to be alone. They express the desire to work in spaces that will give a clear statement of what they are, what they can be used for, so that everyone can easily take a place or have a place. And this reminds us of Bruno Zevi, who was writing that a building must express what it is and what its purpose is, no more, no less than a man. Men who pretend to be what they are not, they displeases us. We also dislike buildings that will give themselves a monumental or functionalist mask. So in architecture, as in life, truth goes with function. In other words, in the layout of the space of a hospital, according to what healthcare provider were saying, it should be clear what it is. What is the project of the hospital? Who the users are, who is expected to come there, and what has been planned for them? What is prepared for their comfort or for the comfort of their bodies? Because as one nurse said, how the body is placed and allowed to be seated contribute to mental stillness. If you are not comfortable, if no one has done anything to make you feel comfortable, it will create mental uneasiness, mental unrest. So you will enter the doctor's room, just nervous. And when we go deeper in this idea of space for care or health provider desires in terms of space of care, there was this a couple of thoughts that they were like to me, because they were related to the nature of the kind of hospital we want for the future. Now that we are facing a kind of epidemic of chronic diseases that is somehow attributed to the choices that we are making every day about what we eat, if we exercise or not. In the North, the idea of working on well-care rather than healthcare came forth, with the idea that maybe we have to forget the name hospital to move to facilities outdoors that will help keeping people in good health or reinforce the determinants of health. Meaning that we should come out of our habits of thinking hospitals as buildings to a movement where the buildings are going to serve different purposes, as architecture and urban planning are going to be focused on keeping people in good health or in a state of well-being. So if everything in our surrounding is planned to keep us in good health, what are going to be the name and purposes of the facilities and building that we are calling hospitals today? So that's among the questions that we are trying to answer in our network. And I think there's still a lot of things to say about that, about the hospital, what it means to be a hospital, what are the functions of the hospital, and what about Africa? Are we supposed to follow the European standards? Are we supposed to follow the and Marimol, I think, showed that multiplicity, that idea of multiplicity in biomedicine, meaning that if you have a GP here and another GP next door, maybe they are not going to deal with their patient the same way. So we should have that in mind when dealing with this idea of the hospital of the future. And I am convinced, as one of the nurses, we were discussing the idea, and I asked her, so what about you? What about the hospital of the future? And she answered, really, she just made this statement out of the walls. And I'm sure we are moving towards that. Thank you.
Thank you very much, Josiane. And yeah, if you can stop screen sharing, we'll go back. Perfect. Thank you so much. There's so much to pick up on there, and of course from our audience as well. We've got like a lot of very involved people here. I just wanted to say I think that one of the things that really interests me is this combination of looking at objects, like physical objects, and then also looking at feelings and emotions and moods and states. So you have people and objects, and perhaps one of the things that joins them is that concept of stretching that you mentioned. So the gates stretch for the hospital. And it also reminded me of a paper that I read for my PhD research called, it's about the Zimbabwe bush pump by Anne-Marie Mole and Marianne Delay. Yes, so they talk about the bush pump that it has porous boundaries, and that those boundaries have to encompass the users who use the pump. So the pump is not a discrete object described by its skin. It's actually something that includes other people and other dynamics into it. So yeah, that resonated with me, the concept of stretching. Yeah, plenty more I can say and will say given the chance, but let me ask if there's anyone in the audience who would like to respond, make a comment, ask a question. And I know we have several people here who are working in the same space in terms of medical humanities and science and technology studies. And would any of you like to put up your little yellow hand? Yes, I see Fanny is here. So Fanny, I'm going to ask you to unmute and also to put on your video if you can.
Yes. Can you hear me?
We can hear you.
Yeah, and I think you can see me. I don't know. I can't.
We can't see you.
Anyway. Oh yeah, sorry. Let's see like that, maybe.
And
Sorry.
I think one of my co-hosts will perhaps spotlight you. There you go. Got it.
Yeah, thank you so much, Josiane. There's so many interesting aspects in your work. I mean, and therefore I would have so many questions, but I would maybe comment a little bit out of the blue. I really like the framing with we're starting with Alma-Ata actually, and and I would like to hear more about. I mean, Alma-Ata at some as your point of departure, and where you end up with imagining the hospital of the future. I would like to see also how do you envisage also the question of the political economy of hospital or hospital without walls, and these different ways of envisioning healthcare and well-being that I really like. So I'd like to, questioning about the financing, because obviously Alma-Ata was a huge question about, financing and really challenging the hospital centrism. In fact, if you look for, questions around hospital care in Alma-Ata, there's none. Like it's completely out of the picture, out of the conference. Nothing was said about hospitals, about this level of specialized care. That is still the question, right? Hospital is supposed to be for specialized care. So how, and so the question of the site and the location, but coming back to the actors and the financing and Alma-Ata is very like international public health, and states were really like central in organizing healthcare and had power, and if you look at hospital today, maybe not for Morocco, I don't know, because they're building huge infrastructure. Like, so what's your take on these big? It's even bigger than in 78, right? Where you had these, district hospitals and maybe regional hospitals, but now the tendency is to build huge hospitals, and it's from capital finance, it's from China, India, Turkey, all these countries. So it's still states, but it's also it's also speculative, it's also capital. So I wonder also how you see that, and how the network can also have an idea, I mean, proposition with regards to the economy, to the organization of resources and which resources. So I will stop here and maybe say more later, but thank you.
Yes, those are really challenging questions, really, really challenging. But yes, of course, Alma-Ata was not dealing with a hospital, but basic healthcare facility. And for me, the idea was really access to healthcare facility, meaning that the doctor has to go to patients or to try to ease this access to primary healthcare facility. It was actually a primary healthcare conference. So my idea of connecting Alma-Ata to hospital was kind of trying to expand on the idea of access. That is, access is not, just taking taking a taxi or a motor taxi to go to the hospital. Access can be connected to how the space is shaped to welcome people, to make them comfortable. Like the idea of accommodation, that's really, yes, that's really how I was trying to connect Alma-Ata to hospitals, meaning around this idea of access, because I think it was a central concept in during this conference. Now about the political economy of a hospital. When you discuss with people involved in the building of hospitals, those huge hospitals, you really mentioned, and that's true, that they're building very, very huge hospitals. Now they are even thinking about building city hospital. You mean that you will need a car to drive around the city hospital. And when you discuss this issue of political economy of hospital, really, really important, people will tell you, there's nothing we can do with public services. That's over. If we want hospital to function, we need private fundings. That's the future. The future is public down and private funding up. So yes, and when I was preparing this presentation, I was like, no, I am still trying to find where, if there is any document where, ministers of health or African a politician, where they sat down around a table and try to figure out, this is what we want for our population. This is where we want to be. And this is our strategy. And this is our public health strategy. This is our strategy for hospital. This is how we are going to do to reach this point, maybe in 20, 40 years. I'm still looking for that. And for me, if this, this kind of, I don't really think prospective thinking or strategic thinking is lacking, we will still have to deal with this amount of project and building coming from outside, like imposed, and we will just accept it because it's one more hospital. I don't think if I'm not sure I've answered, but it was really challenging. Fanny, I'm sorry.
Thank you, Josiane and Fanny. Yeah, I mean, I also had similar thoughts just about that giantism of the hospital. That why is that the only path for hospitals? Is this the enormous hospital? And what about decentralization and some sort of like networked hospital instead of like one giant edifice? But as Fanny says, it sounds like the direction is to larger and larger hospitals. And then we've got a question what the motivations are for that, like whose interests are being served by that structure. And then Divine is asking a question which is within the idea of, are hospitals places of health or hospitals are places of sickness? He asks, is the hospital a friend of the poor, or is it just the last resort where or when there is no remedy, where people go to die? And he also says, given its association with the state that's associated with ineffectiveness and incompetence, what is the image for the poor of the hospital? And I'm speaking it because Divine's mic is not in order, so I'm speaking it out.
Yeah, yes, those are difficult questions. Now, the motivation for this giant hospital, again, when you discuss with people involved, I discuss with them about even a university hospital in Africa. And when we discussed, they said, it is not working. It is not working because the buildings are not shaped to correspond to people cultures and how they use space. So when I asked, what are you doing that? What are you still building like that? And they will say, because we are asked to do like that. And one of them gave me an example. He was involved in the building of a hospital in an African country, a very, very huge hospital. And we were discussing, and he said, now we are using a kind of material for the floor. It is a kind of material that is easy to clean. You don't need easy to clean, and you will not have particles. Yes, you will not have those, getting inside the floor and difficult to take off. So he said, we are using that, and that's good for hospital. And when I was discussing with the Ministry of Health, he said, I don't want that. I don't want that because we have to use, I don't know the word in English, le marque. We have to.
I was going to say perhaps one of my colleagues knows what it is, but yeah.
Yes, we have to use that for our floors so that when you enter the hospital, you can see it is a great hospital. And there is also the issue that in Africa, you know, people, they don't go to a hospital alone. You have the family members, you have people coming and going to see to help, to bring food, etc. And this is really a problem in university hospital, because doctor will come and say, go out, they will go out 15 minutes and come back, go out, they will go out and come back. And again, I was discussing that with those people, and they said, yes, we know about that. And now what we are trying is to build, we cannot move from the European standards because they are perceived as the best. So we are kind of copying them. But we know that there are some issues related to the way people in Africa, how they use the space, their culture, how they deal with sickness and disease. We have to integrate that in our design. But sometimes we are also limited by people at the Ministry of Health or the strongmen, because they also have their ideas, as I think Ismeda puts it. Hospital is not just a place where you go when you are sick. It is also a kind of way for politicians to show that they are doing things, a kind of affichage. I'm sorry, I don't know. It's a kind of, yes, advertising, a kind of marketing, advertising, yes. That's also how you have to perceive this kind of movement toward big hospital. Now, hospital for the poorest, actually, the way those big hospitals are functioning on my study site led a university, a doctor, a professor of medicine, to say, now our hospital, our big hospital are for the poorest. Why? Because they are just they are following what is free of charge. And in those contexts, what is free of charge is not quality care. So what you are saying, Divine, is really true. It's true. Hospitals are places where you can catch sickness, diseases. Hospitals are places where people will just, you know, end their life. And hospitals are places that are, can I say it in French?
Yes.
Yes, please.
Yes, c'est-à-dire que, alors, les hôpitaux aujourd'hui sont considérés comme des lieux où on prend en charge les plus pauvres, parce que le financement public est en train de s'atténuer. Donc, il n'y a plus d'équipement, il n'y a plus de ressources, il n'y a plus de personnel, ce qui fait que quand on y va, c'est parce qu'on reçoit des soins gratuitement et qu'on ne peut pas aller ailleurs. Ceux qui peuvent aller ailleurs se font soigner dans des cliniques privées où ils ont accès à des examens, à des technologies de dernier cri, et ils peuvent payer pour ça. Clairement, je me souviens d'un médecin qui me disait, aujourd'hui, notre CHU est un hôpital de pauvres où on vient faire soigner des bobos. Donc, c'est même plus un hôpital de spécialité, voilà, c'est un hôpital pour les pauvres où on vient se faire soigner pour des bobos.
Thank you.
Yeah. Do you want to translate? No, I think it's do you want?
Yeah, do you want to give it just like the briefest summary? Would be.
Yeah, no, I think Josiane, it was very clear also from your previous talk that big public hospitals are now really hospital for the poor who can't afford to go elsewhere because there are exemptions of care. And as Divine is mentioning in the chat, this free of care, free exemption of costs, exemption of fees policies are also those who are supported by international donors,
Yes.
and we know how dysfunctional it is,
Yes.
right? Because then the hospital who are supposed to be self-sufficient and raising funds and raising fees, they are now obliged to let care go for free, and they are not reimbursed by the state. So it creates even more dysfunctions, if that's what you were saying. But if I can just add and take the opportunity, it's very interesting what we're seeing with these big new hospitals, because they're actually built for the elites, the economic elites and the politicians, because the main argument is that several states, they say they want to avoid those who are going abroad for treatment, right? The evacuation sanitaire, which of course it's not everyone who goes abroad, or even Morocco and Tunisia and France sometimes to go abroad for treatment. So it's clearly targeting, like very straightforward, the political and economic elites of these countries, who by any chance will continue also to go
Moving abroad, of course.
Yeah. So that's really a question. I mean, that's why in your talk, it's really, really very interesting that you start with issues around poverty, accessibility, because that continues to be one of the main issues with this hospital of the future, that from what it seems, it will create even more social and economical distractions, right? And also in terms of how they are designed, are they designed to be able to treat infectious disease, to isolate patients, or are they going to be, because this issue of openness is also, I missed a bit of your part of your talk because I had to open here to someone, but I wonder if you mentioned something around COVID, what is going to happen with, I mean, COVID has maybe do nice to our reflection on hospitals, because from south to north, it has changed it has blurred the boundaries also, like you were mentioning about the caregivers in hospitals, and also I think it was true also, I mean, it was clear from what happened in northern countries that also, families were super important also in daily care. So I wonder maybe if you can say a bit about COVID and what it changes for the hospital of tomorrow, and
Yes. Maybe before answering that question, Fanny, I want to add something about why we are shaping. I discussed with there's a specialty in the building of hospital. They are doing programs. They will say will be the shape of the surgical wards. This is going to be how the hospitalization room are going to be like this. And he said, you know what? It is simple. If we want change in Africa, the day the president of the republic will go to a hospital, a public hospital, to be treated, everything will change. If they're still going abroad, their wife abroad, their children abroad, nothing will change. The day they will start going to their own university hospital, to their own public hospital, everything will change. And I really believe that. Now, about COVID, at the beginning, I really think this is a game changer. This will change everything. But now that you're asking the question, I'm wondering if I'm right, because the hospital that will come out in the years to come, they are already, the foundation are already there. So I'm not sure the impact they will rethink the design to take into account what came out with this COVID epidemics. And I did field work in France just after COVID. It was good, they still have that in mind, but I saw that I'm still in touch with the nurses. Things are going back where they were before the pandemic. So yes, I really don't know, but I think I'm not sure we are going to see the changes we were expecting. I'm not sure.
Thank you. Thank you very much, Josiane. I think that's wow, that's definitely a great concept of this, of state employees or ministers or the president having to use government healthcare. I mean, it happened in South Africa very recently that a minister was in trouble for being asked if he used public healthcare, and he laughed in response. So if government ministers sent their children to state schools and used public healthcare facilities, I think they would be in quite a different state to how they are. And thanks for those reflections on COVID. So we are actually at about the end of our seminar period, and I feel like we could probably take the same amount of time again, and I think we should probably do this again sometime as well. I look forward to further interactions and connections between ourselves and Josiane. So thank you very much again for your time and for your expertise and for your generosity in sharing this with us.
Thank you very much for the question, the challenging question. I will still have to work on some of them, and maybe Fanny, maybe we have to follow that, follow from the pandemic to see what will happen if there will be a kind of memories in the design of hospital connected to the pandemic. Maybe we have to follow that. Thank you.
Sure.
Thank you very much.
You.
Thank you, Raf.
My pleasure. Yes.
Thank you.
Thanks all to the audience as well. Thank you.